Hello, my name is Joanne M, and I'm from Advocate Lutheran General Hospital in Park Ridge, Illinois. The advent of fractional flow reserve to diagnose significant coronary artery stenosis has supplemented the angiographic data obtained during cardiac catheterization. Major trials have demonstrated the utility of the FFR modality and its clinical outcomes in patients with multivessel coronary artery disease. Our second case involves a 60-year-old former smoker with a history of diabetes, hypertension, dyslipidemia, and he is obese, now complains of chest pain. His exercise stress test and myocardial perfusion imaging revealed 8-minute exercise on the Bruce protocol, horizontal ST depression in the inferior lateral leads returning to baseline at 5 minutes of recovery. There was a moderate-sized defect of moderate intensity in the apical region, an ejection fraction of 60%. The abnormal results warranted cardiac catheterization to evaluate his coronary angiography. His coronary angiography at an outside hospital includes two areas of 70 to 80% and 95% stenosis in the left anterior descending, involving the diagonal branches. There was a large obtuse marginal branch with a long 80% stenosis. The mid-region of the right coronary artery had a long 90% stenosis and a proximal 60% stenosis. And his cardiac catheterizations were done because he adamantly refused bypass surgery. So cardiac angiography was pursued to identify discrete hemodynamic significant lesions utilizing FFR. His cardiac catheterization indicates an 80% stenosis in the left circumflex artery, and there was a good final result after angioplasty and stenting. The right coronary angiography indicated a 60% stenosis and a 90% stenosis. And after adenosine 60 mics IC, there was an FFR value of 0.86 after the stenting of the mid-stenosis. They're indicating that the 60% proximal stenosis is identified as not physiological significant to warrant intervention. The left coronary angiography indicates proximal mid-segment stenosis of 70 to 80 and 95% stenosis. With a series of interventions, including PCI of the critical lesion involving the diagonal branch, we're able to analyze the importance of the remaining lesion. With the FFR wire in place, after intervention, there still remains a significant physiological stenosis with a FFR value of 0.74. A sentinel was placed in the proximal left anterior descending artery with a good final result. The debate between percutaneous intervention and bypass surgery for the treatment of multivessel disease will continue as diagnostic and treatment strategies evolve. FFR identifies culprit lesions in the multivessel CAD to improve prognosis and symptoms, and FFR tailors revascularization to the hemodynamically significant lesion. Thank you for your time.